Thank you, Nipuni. It's my pleasure to introduce our first speaker for today, Dr. Dileep De Silva, Chair Professor of Community Dental Health, University of Peradeniya. Professor Dileep De Silva is the Chair Professor of Community Dental Health and Director of the Career Guidance Unit in University of Peradeniya. He is a cost and management accountant, chartered banker, and board certified specialist in dental public health. His academic credentials include MD in Community Dentistry, MBA from University of Colombo, a PhD in Health Management from the University of Southampton, UK, and FDS RCPS in Glasgow. He spent 25 years at the Ministry of Health, leading health, HR, and health economics and publishing Sri Lanka's first national health account in 2014. He has also served as a lecturer, trainer, and examiner at PGIM since 2010, with involvement in 4 of its boards of study. Professor De Silva has authored 2 books, 9 chapters, and over 50 peer-reviewed publications. His achievements include numerous national and international awards, including the National AHPSL Award, Sri Lanka, and the Best Young Professional Award from the Commonwealth countries. Professor Dileep will be discussing today on financing healthcare in Sri Lanka. Sir, the audience is now yours.
Thank you very much. Can you see my slides?
Yes, sir.
Okay. At the onset, let me thank your college for inviting me. Though it was short notice, I really appreciate your invitation and I'm proud to be with you all because I always support the allied health sciences during my tenure at Ministry of Health, which exceeded nearly 25 years. So thank you so much for inviting me. And I have taken the liberty to change the topic because I cannot speak about health finance without speaking health HR. So, and I'm trying to keep this short lecture for about half an hour, permitted that. So it's 7:16 now. So I'm planning to stop it at about 7:45 with your permission. So let me move. As I was introduced, I'm Dileep De Silva. Basically, I'm into health finance. But currently working as the chair professor at the Peradeniya University. So my presentation today, since so many health professionals, our colleagues in hospitals are involved here, I'll be touching on the history of the health sector, health HR, health financing. And permitting time, I might try touch on the economic crisis in Sri Lanka and taxation. That is optional, giving on the type, the time factor. So the first about the health sector, I'll be going into depth in health HR and health financing. Then the latter two, with your chair's permission, if time permits. So to begin with, I understand that most of you are employees of the Ministry of Health. And if somebody asks how long your employer or your company or where you work has been, Ministry of Health has been in existence from 1858. So we are nearly 170 years old. So your employee is 170 years old. The origin goes back to 1858 when it was started as a civil medical department. Earlier, before that, it was handled by the British Army, where we were a colony. And more than that, Sri Lanka holds the proud history of having the first delegated hospital in the whole world, right? It became in existence in 4th BC century in the whole world. So our Sri Lanka, by nature, by culture, by history, we are very close to health. It is further evident by the fact that former kings like Buddhadasa was a physician as well as a veterinary surgeon. So we have a history of health-related culture. Coming to the allopathic medicine, which all of you practice, in 1923, that's exactly 100 years ago, we had 1,532 healthcare workers in the Ministry of Health. 1,532 for the entire country. Of course, the population at that time was 4.5 million. And by 2023, exactly 100 years after, we have 150,000 healthcare workers belonging to 270 odd categories, including yourself and myself 2 years ago, because I left the Ministry of Health in 2022. So in 2023, we have 150,000, but that is for a population of 22 million. So what I'm trying to say is over the last 100 years, the healthcare professionals have evolved 20-fold. There's a 20-fold increase in the healthcare professionals over the 100 years, starting from 1,500 to 150,000, whereas the population has only changed from 4.5 to 22 million. So we have a 20-fold increase in healthcare. And at the moment, we have 0.3 healthcare staff per 10,000 for 1,000 population over the last century. Can I move this? I can't see it. Yeah, so we have started from 0.34 for 1,000 population to 6.8. Today we have 6.8 healthcare workers for 1,000 populations, which is a very good achievement by the economic perspective of Sri Lanka. And as you know, we have the central government and the 9 provincial councils. As of 2023, we had 1,126 healthcare institutions with a total bed strength of about 78,000. And the line ministry manages 51 tertiary care and secondary care institutions, and the provincial councils, they manage 1,075. Number-wise, huge. That includes all the primary healthcare and very few secondary care institutions like some few base hospital Bs, and also not forgetting the 354 MOH areas. But sadly, when it comes to finance, 75% of the budget, between 73 to 75% of the budget comes to line ministry institutions. Whereas all the provincial councils gets only about 25% of the health budget annually. So that's how our financials are distributed. This is the sort of a glance of the current healthcare staff in the Ministry of Health. We had about 2,300 medical consultants. Now we have lost about 200, migrated. Now we have about 2,100. We have 21,000 medical officers. We have 44,000 nursing officers. Huge, that's the highest professional category. And comes your PSM categories around 9,000 to 10,000, and midwives 9,000. So these are the key categories, healthcare profession in the government sector. And all of us together, we are catering for 58 million OPD patients. 58 million. So one might think, how can it be 58? Because the Sri Lanka population is 22 million. That is because repeaters are there. Certain people on average, they come at least 2 or 3 times to the government sector per year. So you cater for 58 million outdoor patients per year, 7 million indoor patients or 7 million admissions per year. That is 1/3 of the population, if we go statistically, and 3 million clinic attendees. So all these 58 million, 7 million, and 38 million are catered by you in the government sector. Coming to the private sector, there are about 1,300 full-time general medical practitioners. Mainly, they cater for outdoor patient care. And these full-time medical practitioners in the outside or in the private sector are supplemented by the government employed doctors, where there are studies to show about 70% of the government sector employed doctors do work part-time in the private sector, which they are loved for. So currently, there are about 192 private hospitals registered under the private sector regulating authority of the Ministry of Health. And speaking about the private sector healthcare market, in economic terms, we call it an oligopoly market because there are only few players who owns a bigger share of the market. If you consider the private healthcare market in Sri Lanka, there are 5 big players. There are 5 companies or 5 hospital chains which owns more than 70% of the private sector healthcare market. You know them. I would not name them, right? There are 5 big players who own 70%. And the economic feature of the oligopoly is that these firms or these corporates, they will not allow a small man or individual firm or company to come up. In order to prevent that, they start branches in big cities. And I did not emphasize the fact, you can see it for yourself. The original hospital which started in Colombo, now you find in big cities like Matala, Kurunegala, Jaffna, Kandy, all the big hospitals are going there. So that's a feature of an oligopoly market. And also they go into differentiated products. That is, some hospitals are now catering only for maternal and neonates, whereas some other hospitals are catering for cardiac. So that those are the textbook types of oligopoly market, which we are having in the health sector. So once again, 5 big companies, you know who they are. They enjoy more than 75% of the healthcare market financially in the Sri Lankan context. Then coming to training of health staff, as you know, up to about 2007, all the doctors, the dental surgeons, and the medical and dental specialists were trained under the higher education by the university system. And all the other categories were trained by the Ministry of Health. So I'm very happy to see the allied science faculties came in to the sector somewhere in 2007-8. Now we have currently degree programs in nursing, medical laboratory technology, pharmacy, radiography, and physiotherapy, etc. in about 7 state universities. So, but unfortunately, still, they're not producing the number the country wants. For example, nurses, the Ministry of Health trains 3,000 per year, where all the state faculties train only about less than 500. So the state allied science faculty should gradually increase their intake. So this is one of my publications. This is the recurrent cost. Recurrent means without the capital cost to train one undergraduate by the state in the universities. Come for law. Law is a 3-year degree, 259,000 per year, and it comes to 1 million. Can you all see this? Hello?
Yes, sir. We can see it.
Okay, I mean, my tone is good and you can understand?
Yes, sir, of course.
Okay, so the law for state spends about 259,000 per year, and for the law degree is about 1 million for the 4-year course. Business administration, 269,000, again 1 million. Science, 1.3 million. On the last column is the total cost. On the middle column is per year. And allied sciences, your field, is a 4-year program. The state spends on the recurrent expenditure 530,000 per year per student, and we are spending 2.1 million for each and every graduating by the allied sciences, only the recurrent. And also, mind you, this is 2020 costing. This we'll have to inflate it about at least 15-20% to bring it to 2024. And I'm working on 2024 now. So if I do this lecture next day, it will be updated to 2024. Engineering, 561,000 and 2.2 million. Medicine, 836,000 per year and 4.1 million. Come dentistry, which is the most expensive course anywhere in the world, 1.7 million per student per year, coming to 8.6 million. So this is what we are spending. So I would like to see allied sciences increasing their intake, and you can reduce even the per cost and producing more and more allied sciences via the health ministry and for the private sector and even for the export market. So there's enough room. And this is what the Ministry of Health spends to train our diplomats in our training schools. I think most of you may have started with this and then top up with the degree. Nursing, we spend about 1.3 million for a 3-year course. And the PSM and para categories, which were 2-year courses, we spend about 900,000 or 880,000. This is only the recurrent expenditure, and this is 2022 figures. So I'm just giving a flavor. This is all taxpayers' money, and we are privileged to be trained free of charge for 3 years, 2 years, 5 years, whatever, depending on the category. Coming back to medical education, many might not know that the first medical school in Sri Lanka was established in 1848, more than 150 years ago, or nearly 180 years ago, by Dr. Samuel Green, and it was in Jaffna, Manipur. and still it functions as a cooperative hospital. No medical school is there now. And they trained for about 4 or 5 years, and all of the trainees got jobs in Malaysia and Calcutta in India. Then the formal medical school, which is the medical faculty, Colombo Medical Faculty today, started in 1870. And it took 90 years to start the second medical school in 1960 at Peradeniya. And from 1978 to 2023, within that 45 years, we have started 10 new medical schools, and currently there are 12 government medical schools and one under the defense, which is the KDU. And as you all know, all of us came to the university from this quarter, the students to the state medical faculties, and for the other faculties as well. 40% are selected on merit and 60% are selected on district basis. And according to 2022 statistics, about 40,000 students had GCLR from bioscience in Sri Lanka, and we selected 2008 for medicine, which is 5%, relatively high percent. This 5% is even larger than the intake in UK. Out of the applicants, or out of the people who sat for the exam, 5% were able to get into a state medical faculty. And also now we are getting more and more foreign qualified doctors. In about 20 years ago, in 2023, there were only about 80 students who sat for the ERPM examination. That is the examination for registration to practice medicine, or simply we call Act 16. There were only about 80 students. Now about 300 students, or more than 350, sit for the ERPM examination every year. And out of the medical workforce whom you all are working, 16% are now foreign graduates. So if we take 100 doctors, 16 to 17 are foreign qualified Sri Lankans. About the allied sciences, in the past, allied science professionals were trained by the Ministry of Health, now partly trained by the faculties of allied sciences, as I mentioned. In future, I think all the training should be done by the universities, and the paradigm has to shift from the diploma or high diploma to a degree programs. That should be the way forward in the next form, at least starting from next 5 years onwards. And also we have a huge issue with feminization of the health workforce. As I told you, we have 150,000 health staff, which is including 44,000 nursing officers. And as you know, 95% of the nursing staff is females. So that's 42,000 itself. So out of 150,000 health staff, 42,000 female nurses are there. And all midwives, as the name suggests, are females. So another 9,000 it's there. And overall, about 60% other staff also, like the doctors, the other minor staff, they also about 60% are females, including your professionals, and totally about 70% of the health staff in Sri Lanka, 70%, huge amount, are females. And these are one of my publications from 1990 to 2030. In our days, I entered the university in 1990. We had only, female students only 43%. That means 57 were males. Males were dominating. And come now, in 2024, 64% are female. That is 36% are, only 36% are males. And within the next 5 years, the males will go up to 73% in the medical faculty intake, 73% females. So there will be only about 27% males. So if you see the consultants, even now, 83% of the board certified microbiologists whom our lab scientists work with, 83% of the board certified medical microbiologists, whom we train from in the 21st century, are females. 83%, huge. Dermatologists, 64%. These are the PGIM data from 2000 to 2023, 64% are females. Radiologists, yes, balancing half-half, 51% males and 49% females. Look at this, orthopedic. We have trained 90 orthopedic surgeons in Sri Lanka from year 2000 to 2023, 90 orthopedic surgeons, both certified consultants. And out of that 90, ladies and gentlemen, 89 now females. Sorry, 89 now males. So what would happen? So according to this graph, this table, If you want to become an orthopedics consultant in Sri Lanka, first you have to got an MBBS degree. Then, secondly, you have to be a male. But what would happen in future? There won't be male doctors. 76% will be female doctors. Then who's going to do orthopedics? So that is a query which we'll have to answer very soon. There are only two options. Either females will have to take into orthopedics or we'll have to import them from India. What are the HR issues with increasing feminization? We have to consider the maternity leave and leave for subfertility. As we know, when during my tenure in the ministry, we brought a cabinet paper. We are giving 1 year special leave for subfertility for the women healthcare workers. And the women tend to select specialties which are not that heavy or which you don't have on-call duty 24/7. And females are a little bit reluctant to take into surgical specialties, as I shown from orthopedics. And in time to come, there would be flexi hours. You will not be employed full time. You'll be given flexi hours, that is, you work from 8 to 12, and afternoon you take care of your home front. And part-time employment, those are the things which will happen for the healthcare staff in future. In other countries, it has already happened. For example, National Health Services in UK. And there would be employment gap. You may be able to take leave for so many years and come back after your children are grown up. So the migration, as I said, is a big issue. When you consider migration, there's two words, in-migration and out-migration. In-migration means people, foreign nationals coming to Sri Lanka. Sad to say, even today, we have only 10 foreign nationals. Sorry? We have only 10 foreign nationals, medical professionals working in Sri Lanka. All of them are based in Colombo in private sector. Only 10 foreign nationals, and we have about 60 foreign national nursing staff, again in the private sector. So very few foreigners are working in Sri Lanka. When you compare with the National Health Services UK, 33% of the doctors and the health staff are foreign born. They're born in foreign countries. In Sri Lanka, only 10. You can count them from the fingers of your hand. But what we have is the out-migration. And as you all know, allied health professionals, doctors, the consultants, nursing officers, everybody's trying to go abroad. That's lead to out-migration. And the hardest effect are the PGM trainees. As you know, once they complete the local training, we are sent to developed country for 1 year foreign training. And normally we send about 280 foreign postgraduate trainees abroad for 1 year, and normally about 250 to 260 return. So that's a lost about 20 over the last so many years. But recently, out of that 280, only about 150 returned. So we have lost 130. The effect of this will not come immediately, but these young consultants, they are going to be the backbone of the system in 5-10 years time. So at the moment, we are not getting the trainees back. So there will be a vacuum of consultants in future to come. And also this was more aggravated by the fact that the government went and gave 5-year leave schemes for government officers to engage in foreign employment. That has aggravated the problem. So under the 5-year leave system, 97 medical consultants have officially taken leave. And most of the, we have lost about 1,500 to 2,000 nurses. And unfortunately, most of these people are going for underemployment. That is, they are going for jobs which require far less skills than the job what they are going abroad. Right? They should have done that job. For instance, most of the nurses are going as caregiver assistants. So our nurses, we are highly qualified, well-trained. Unfortunately, they go as healthcare givers. And the doctors even go as locum. Doctors, locum means your job is only for 1 year. Unlike here, this is a lifelong job. So just to complete that, in schools for the 13-year education, we are spending half a million rupees for all of us by the government for our 13 education. In the medical faculty, as I showed you, 4.2 million for the 5-year degree and 13 million for the postgraduate by the PGIM. So altogether is about 13, 5 and 7 is 25 years. You spend 25 years and 18 million, and at once they cut off the tree, which we took 25 years to grow into this level, and they migrate sadly because this taxpayers' money. So this should be curtailed at some stage. Just to make you aware, can you see this world map? I want somebody to answer.
Yes, sir.
Okay. What are the three countries I have make? Come on. I put the name of the country is marked in red.
Yeah, Australia, Sri Lanka, and this is
Niger.
Nigeria.
Good. No,
Niger.
Niger. Nigeria is a big country. Niger is a small country. Niger is a Central African country. And what is the common factor in all these three countries? Come on, we are running short of time. What is the common factor? I put it there.
Same population.
Yeah, the population is almost the same, right? Okay, then I'm going to test your intelligence. Okay, now, and even some of other professionals, they think the number of doctors, the number of physiotherapists, number of nurses, number of ophthalmologists and optometrists, number of lab technologies depends on number of population. That's what most of the politicians think. So, ladies and gentlemen, if you consider only the population size, as you correctly said, these three countries have the same population. If you consider only the population, can you tell me how many pharmacies or how many MLTs should these three countries have? Come on. If you consider only the population, how many medical lab scientists should we have? How many physiotherapists should we have in the country? I want somebody to answer. If you consider only the population, come on, Lasantha, Ravi. No need to calculate. If you consider can you hear me now? Hello?
Yes, sir.
Yeah, if you consider only the population, how many doctors or how many lab scientists or how many nurses or how many physiotherapists should these three countries have? Come on.
Has to be same number?
Yeah, it should be same number because the population is almost the same, right? So that's what the politician thinks. They think, okay, in Australia, there are so many physiotherapists, so many doctors, and we also should have same doctors. Can we do it? Can we have the same number of doctors or same number of physiotherapists or same number of speech therapists in these three countries? Yes or no?
No.
No.
No,
Why?
sir.
Why?
Because of the income.
Yeah, because of the economy, right? The per capita GDP gives a sort of overview of the economy. Say the Niger economy per person gets only US dollars 590 per year, 590. Sri Lanka per capita income is 3,800, right? So we are 15 times more bigger or more robust than Niger. And Australia is almost 60,000. So almost 60,000. So their per capita income is about 15 times more than Sri Lanka. So when you consider the economy, these three countries cannot have the same number of medical staff because the economy is small. So if somebody thinks, okay, Australia is having 60,000, for example, Australia is having 180,000 doctors, we also should have it. No, we can't do it. Our economy is 20 times weaker than Australia, right? If somebody thinks Australia is having so much of nursing officers, we should have it. No, we can't. Our economy is only 1/20th of Australia. Same for Niger. For example, I'll tell you, Sri Lanka, we have about, we had 210 dermatologists. Now we have about 92. The other 96, I think, others have migrated. And Niger has only 6 dermatologists, 6 for the entire country, same population, 20 million. So Niger can't say, look, there's a country called Sri Lanka. There are 96 dermatologists. We have only 6. So we have to produce more and more and more and more and more and dermatologists. No, Niger can't do it. The economy is not strong enough. They can do it. Then they have to stop the primary education, secondary education, road network. You stop everything and produce dermatologists. No, it will not happen. So you cannot consider only the population of a country when you decide the manpower. So I think the senior members of this union will have to take this message when you go for your discussions. Don't just consider only the economy, but you have considered these factors: the size of the economy, the physical space, that is how much money could be given to health sector without jeopardizing the other sectors. So our fiscal space is very limited. We don't have money. Our total income is about 68 billion US dollars, 68 billion, not million, billion US dollars. It's a small economy. So with that economy, actually, the Google company's annual income is about 160 billion US dollars. So ours is only 70 billion. We were 90, but it has come down to the economic crisis. So we are, and in that sense, the Google company can buy Sri Lanka 3 times. Not that we are going to sell it, right? So we have to consider the fiscal space and the health system and the financing method with the pre-for-health of insurance system, we have to, and the country's population and its geographical size. So sadly, our politicians, they are considering only the 4th one, and therefore they are mismanaging the most of the time what is the manpower requirement. So I hope I conveyed the message to you on that. My last or the final section, health financing. Though we call the free health sector, 45% of the healthcare is borne by the government, and the private sector contributes 48%. This is asset of 2020, and the balance 7-8% by the insurance companies, international agencies like WHO, World Bank, and the employers also pay the big companies. And now out-of-pocket expenditure now is nearly 50% or has showed a rising trend. And I would think by 2024, our out-of-pocket expenditure may even exceed 60%. Out-of-pocket expenditure means you are spending from your own pocket. So though we call a free health system, our out-of-pocket expenditure is very high. So this is the money what the government has been allocating for health sector. In 2013 is 70 billion, and by 2024 it has come up to 400 billion. So one might say, okay, we have spent from 70 billion, we have increased up to 400 billion. Yes, that's good. We have increased, but if you consider as a percentage, despite the increase, the government still contributes less than 2%, less than 2%, 1.9% of GDP on health. World average is about 8 to 10% of the GDP has to be spent on health, but Sri Lanka is spending a little bit less than 8%. And totally, that's the government, totally government and private together, our total health expenses is about 3.4 or 3.2, it varies between 3 to 4% of the total health expenditure. And my last few slides. Ravi, can I go on for 2 slides? Whoever the chair here?
Sure, sir, you
Yes,
can
sir.
go.
Okay. If you have your attention to the slide on my right, my right side, the purple, the bars, the purple component is domestic funding. That means if our health expenditure is 100, for example, the purple component is domestic, means the Sri Lankan government or Sri Lankan people, they fund it. And the orange one is the foreign. So what it says, can somebody say what's the meaning of this? Right? That is, out of our health budget or health expenses, more than 95%, nearly 95%, sometimes some years 98% are by the domestic funding. Or the big agencies, big names, they sponsor only us for about 2 or 3%. But when you are an outsider, when you see the news, you think as, of course, they are running the health system, big agencies. I would not name them, international agencies. But in the reality, say I have done this from 2015, right? Out of the health expenditures, more than 90%, definitely more than 90, sometimes reaching 95% are by the domestic fund, either by the people or by the government. Only small portion, which is shown by the orange, is given by the foreign agencies, including WHO, World Bank, UNICEF, Red Cross, you name anything. So they are giving only about 5%, right? So in my personal opinion, even if those agencies are not there, still we can survive because we are already spending 95% of the health budget. They are giving only less than 5 to 7%. And if this is bad, ladies and gentlemen, this is the worst. And even the small amount of money they give, see, the purple ones are the grants, the other ones are the loans. So they give little funds. And out of those funds, more than 90% are loans. We have to pay them back with interest, right? So you have to understand, health system runs from our own funds, not from foreign funds. In a country like Afghanistan, WHO produces about 70% of the health budget. Yes, of course, then we have to say, yes, you all are doing a good job, because if WHO leaves, the country will collapse. But here, 92% of the funds are domestic funds. Foreign donors, they contribute only less than 5 to 6%. And out of that, 90% are as loans, not as grants. Loans we have to repay. And another issue we have it, out of our health budget, nearly 80% or a little bit more than 80% goes for recurrent expenditure, not for capital expenditure. How it manifests at your end is you have no equipment, you don't have any new areas to practice your profession, you cannot bring in new technologies because our capital budget is less than 15%. Whatever the money we have, we are running on recurrent budget, on spending for recurrent expenses, which is mainly salaries and wages, which takes 50%, 52% of the budget, and the pharmaceuticals takes about another 30%. So we have very little budget for health expenses, capital expenditure. There's another issue. These are my last two slides on the core areas. We say we have no money, but if you consider the recurrent, these are the 9 provinces, because I thought some of you may be working in the provinces. These are the recurrent expenditure. So every year, we allocate a certain amount of money, which is shown in blue for all the 9 provinces, but the expenses overshoots that. Every year, the expenses more than that. How is manifested that at the end towards August, September, October, your hospital finds it difficult to pay you extra duty payments even, or whatever the allowances. They don't have money. But this is poor budgeting. Every time the recurrent expenditure exceeds the allocated amount in the recurrent fund. And this is the capital fund. Allocations are more, but you can't spend, right? So there's a big issue of spending capacity of the provinces. So we give them funds, right? And they need the funds, but they don't have the capacity to spend the money. As you can see, the red ones, actual expenditure is far less than what we have given money. And so there is funds, but you have no capacity to spend it. So these are the things which should be addressed in future: capacity building. And health is a teamwork. It has to be shared by all the healthcare professionals, given equal, or sort of like getting their contribution maximum to all planning and execution of the budgeted allocations. So that's about the health finance and health HR. So I think if you want, I can stop it here, or I have about 4 or 5 slides going to the economic crisis and taxation, but I have exceeded my time. So it's over to the chair to decide and let me know.
Of course, you can go ahead, sir. Please
Okay, thank you. But am I disturbing the other 2 speakers?
Yeah, sir. I need elaborate one point from your side.
Yes.
We are always proud of clinical capabilities of Sri Lankan Free Health Service.
Yes.
But we discussed the health economy in Sri Lanka very less often.
Yes.
My point is, as you said, over the last 15 years, we have spent more than 50% of out-of-pocket on health expenditure.
Yes.
Given this, how can Sri Lankan health service truly be considered as free health service?
Yeah, you can't consider, because
how we explain the situation where this out-of-pocket money will spend 95% of coverage given by the free health institution and free health service.
Yes, a very good question, Ravi. Out-of-pocket expenditure mainly goes for pharmaceuticals, which may be not available in the hospital for certain people on a certain day or certain period. Pharmaceuticals, laboratory investigations, radiological investigations. So that is, when you go to the government sector, you are being asked to get those things outside. So that's one segment of the out-of-pocket. The other out-of-pocket is, people may have money. The services are in the government sector, but the people, they want to have the convenience. They want to see the doctor after their working hours, maybe after 6, but the government hospitals you don't find. So they go to the private sector at the convenience. The other factor is, if you go to the government sector, right? If you want to meet a surgeon, you can't meet the surgeon straight away. You have to go to the clinic, then the HO or the SHO will see into that. Then the registrar, the senior registrar, and finally to the consultant. So if somebody wishes to meet the consultant straight away, they go to the private sector because there's no gatekeeping or no reference system in our system. So those are the main contributors to the health sector, to the out-of-pocket. One is the unavailability of some drugs, certain drugs at certain times, unavailability of certain reagents, certain chemicals at certain times, not at all times, and unavailability of certain radiographical investigation like MRI, radiological investigations, MRI, CT at certain hospitals, certain times. So the patients are opted to go outside to the private sector and do it. That's why the healthcare expenditure out of pocket is rising. And top of that, in the private sector, people go to the private sector for the convenience, not necessarily because you don't have those factors, you don't have those services in the government sector. We do have it in the government sector, but they go. So in order to answer this, one thing we have to strengthen is the gatekeeping, the referral system. And nowadays, if anybody wants, even if you have a headache, they will go to the neurosurgeon. The primary healthcare system will bypass. So now I think the ministry is working very hard with the leadership of Dr. Mahipala to strengthen the primary healthcare system and tackle the small things at the primary healthcare level, so the people will not spend out of pocket at the larger level, at the very top level. So I hope it answered my question.
Yeah, so thank you very much. I think we should discuss about that money and actually we are in the free health services or not. I think your next slide is very important, but the time is
Yeah, I think we better stop because otherwise I'm not being fair by the other lecturers.
But
so then,
that lecture is must for us. We will prepare the next time for your that lecture too.
Okay, then thank you very much. If there are any other questions, I can take. Any more questions? Anybody? You can ask in any language. I hope it was interesting.
Yes, of course. That was so impressive. Thank
But
you,
I
sir.
normally don't like to do online lecture where you can't see each other. It would be much better if I was able to do a physical lecture. Anyway, that's how the things are going. Any questions? I mean, you can express your opinion even. So either it was very clear or you didn't understand anything.
It was very clear, sir.
Okay, then. Thank you very much. And you have to pardon me because I have another appointment at 8 o'clock. So I told Ravi that I'll take it up on 7 to 8 and I had to rush into that at 8 o'clock. So it's about 2 minutes to 8 o'clock. So once again, thank you very much, Mr. Ravi Kumadesh and his team for inviting me. And I hope I did justice for your invitation. Thank you.
Thank you, sir.